So how do you follow patients? Again, I think the rule of thumb while your patient's on therapy is that the patients are seen and labs are done every single time the patient is treated. When there's a decision to take patients off therapy, either because they've had a complete response or they've developed unacceptable toxicity where you just decide, okay, you've maximized the benefit, it's time to take you off drug. These patients, at least for me, get seen every 3 months. If they've had metastatic disease, they get imaged every 3 months for the first year off of therapy. Once I'm convinced that they have stable disease after a year, I go to every 4 months for the second year. After that, they usually get imaged twice a year for year 3. Because we know that once they achieve that durability, usually after 2 to 3 years, at least I'm becoming pretty comfortable in thinking that patients are going to remain either disease-free or with stable disease where I don't have to follow them so closely. I still see them in the office every 3 months in order to assess that they don't have anything else going on. But again, this is a new horizon for us. We've never had anything that's been this effective. And so we now have to start making up the rules for how do we follow this patient and what do we do and what do we look for? We don't know. We're writing it now. And hopefully within the next year, we'll be able to provide docs throughout the world with guidelines as to recommendations, how to follow these patients and how to manage them both on and off therapy. 50% response rate doesn't equal 100% response rate. Not every patient is going to respond to cemiplimab. I think depending on the patient's situation, depends upon what do you do next. If the patient has had some response, that would then render them surgically resectable. If this was something that was locally advanced and you just decided, wow, instead of having a life-threatening or life-disfiguring surgery, it might be easier to see if we can get this tumor to shrink up and then send the patient to the OR for salvage. And I have done that where I get some response but not enough response and the patients just stop responding and I just want this tumor removed. And the patient can now successfully go to the OR with a less invasive and disfiguring surgery. If the patient has metastatic disease and doesn't respond to cemiplimab, I'm not a big advocate of going second-line chemotherapy, again, because we know that there's no durability and response rates are low. I advocate that they participate in a clinical trial. There are a number of different trials that are looking at combining different strategies of immunotherapy, taking the base that we have with anti-PD-1 therapy, combining it with another immunotherapy. There's also going to be some trials that are going to be looking at taking immunotherapy and using tumor-directed therapy, where you actually either inject or treat the lesion with a topical or an injectable immunotherapy. So I think we're still leaning down that immunotherapy road as to how do we take that 50% and make the 50% to 100%. So we're just building on the PD-1 story and trying to make that better.